So we're going to start to open it up for discussion in here, but thanks for all three of you for really doing a great job of pulling together obviously very complex discussions that are going on. You're not off the hook. We do think that a lot of the work that gets done in the forum happens between the workshops, and so we will be coming back. So this will be captured in here, but I think we've got some thinking to do as well, and building forward some of the recommendations in here and making them very strategic is an important next step. I did think as we talked about this, I had sort of a sense of maybe 8 points that together that constitute actionable data that cross all three of these settings in here. And I thought I might think about listing these, and then I think I'd like to let Bill have any comments in here and then open it up for general discussion for the remaining part of the session in here. But actionable data really is, I think, the key. It's not that we want to collect data because we just want to know, we want to do. So it has to be relevant, and I think that's the common theme for everything in here. The relevance includes well-being. I think some of the groups were continuing to say about well-being. It has to be accurate, or at least sufficiently accurate to be able to make judgments about what kind of changes you might have from one time point to another. Is that a real change in the data, for example, from one year to the next, and should that make decisions in here? It should have accessibility. And we had an example that Jane Pearson talked about, the Whisker system, for example. And I remember the Whisker system at CDC previously. If you wanted to find out what the suicide rates were, it would take you about a day or so to go through that. And now to be able to get that information immediately on a mobile app, I think is moving in absolutely the right direction for making that information accessible in here. It obviously costs quite a bit in here, but I think it's an important step for us if we're going to make things happen on the time scale that people make decisions in here. It has to have timeliness. And we had some examples in here. Medicaid data we know is behind the times. The national the national vital statistics we know is several years behind. It's really troubling that we have national data around mortality that we don't know about until 3 years later. It's a huge problem in here to try to address some of those issues. But obviously we can get strategic about some of the data that we have. So timeliness is another issue. I think another issue is what we might call criticality. That is that these are key variables we think of. And we've talked a lot about outcome measures, to follow and track outcome measures, system measures, risk and protective factors. We haven't talked about mechanism very much. If you're really thinking that you have a strategy for intervening and changing children's developmental trajectories for cognitive, affective, and behavioral health, there are going to be some key mediational pathways that we should recognize in here. They may be related to community mobilization and change. They may be at a parent-child communication level, for example. We have to have sustainability of these data systems. It's pretty obvious, I think, that we need to do this one. And transportability, that is that we want to take the great examples that we heard about today, be able to try and make them useful for other settings as well. And the final thing, I think, is what I would call something like embeddedness. We need to build a culture where we have using data as a knowledge base for where we are and what we need to do next is, I think, the key theme in here. We do not have that yet, but I think that process of engagement in here, I think, is really useful. It not only is talking about communities in here, but you know, as Greg Farber was talking about, there's a new day and age about the use of making data available from research studies as soon as possible. And I think that's ultimately one of the major important goals that we need to do. So those are key principles in here that I have. So.
I would just say each one of the groups did a fantastic job. I think the only thing I would add to Hendrix's list is acceptability to the users. That is, the data has to be acceptable to the families and able to be used by them. It has to be used by the frontline practitioners under the ACA, and it has to be useful for policy and research. And those are achievable goals, but they require, investment in those. I think the other thing I would say is that data systems are not static. They're interactive. They change over time. Tom and our group was talking about how we're going to rely in medicine more on biological markers and mechanisms as time goes forward. And so we need to build systems that can be flexible and integrate new parameters. And that does require some investment in startup costs and making systems compatible, and some ongoing investment in continuous quality improvement in data systems, along with other things. So.
Good. So we want to open this up for discussions and comments from the people here, as well as our leaders.
We have somebody over here.
Please, go ahead.
Hello, Felicia Bowen from Rutgers School of Nursing. So I think the panels all did a great job. I just want to make sure that we don't lose a couple of things. First, the differences. I think the first and the last group talked about these developmental differences, and it makes sense to us, but when we are trying to report this out or share this information with people who live and work in the adult world, especially in terms of measurement, we need to really stress to them that it's not just kids or children, one size doesn't fit all, that there are these specific developmental differences, and so we need work in each one of those areas. I always tell my colleagues that, people say it's pediatrics. It's not just one specialty, but we have a whole spectrum of folk in there. And then the other point on differences is that when we are looking at measurement instruments, that again, it's not just children, but we need to understand that there are Latino children, there's African American children, there are American, Native American children, so that these instruments and measurement tools that we have are culturally relevant as well.
Other comments?
I just want to follow on what Felicia's saying, because the number of kids that are going to come from minority backgrounds, and the language. Talking with somebody. But 17 different languages in one high school. So how do you take measures and make that? And that's in Kansas City. It's not Boston or Los Angeles or somewhere where you anticipate a lot of issues around language. So 25% of kids below the poverty level probably in 2020, 2025. What does that mean in terms of health literacy and other types of factors? So taking into context the children and families, the characteristics of the children and families we're going to be serving as we think about measurement also.
This group isn't the first group to talk about trying to develop a more comprehensive measurement system. CDC has been heavily involved in this one. The IOM that Tom and Bill and others were on said the same thing. How do we get there?
One thought that I have in terms of developing these instruments so that they're meaningful and that we're getting data that means something, I know we talked about using the feedback or using the data from the measurement instruments to share with parents, to share with caregivers, so that we're educating them in the process and making them more open to sharing. I think that we really need to invite parents and people from these different groups to be at the table. What's important to them? What are their outcomes? What do they want for their children? I mean, we may say graduating from high school. I mean, I would like that for my child, but for somebody else, it may be having my baby live to be 5, or I don't know what it is. It could be something that extreme. It could be something else. But what's important to them? So we really need to have parents and representatives from those people groups at the table to help educate us, and so that when we're measuring things, because if we want to talk and give back to them, we need to talk to them about things that mean something to them. And if we don't ask them what we should ask, we're going to miss out on that.
I've been going to meetings that have come up with similar conclusions and directions like this twice a year for 20 years. There are certainly some new issues, and I think a lot of them have to do with how researchers use this data and accept this data. But a lot of the issues around the technical aspects of this are not the obstacles to doing this. We live in a country that we all value our privacy, while at the same time we give up our privacy every single minute. We live in a country where at least a lot of the country values state independence, city independence, individual independence from the federal government. And we live in a country with a lot of federal legislation and laws and rules and regs that prevent the things that we're talking about here. And so where you start to address some of the technical issues are not the obstacle. The data is being collected when you use it, you address the technical issues. You realize, just like any other research project or analysis, you realize the weaknesses of the data and you work around them, or you do something to make it better. You can combine survey data with administrative data. It's been done in many different places in many different areas. The issues are the rules and regs that I think reflect how the public feels about the privacy of the data, their trust in government to handle this data, and a lot of the issues around cultural issues and what the families and frontline practitioners get out of this type of work.
Andy Scher from Autism Speaks. Just to talk about that model, one model in terms of trying to develop a tool that may be more universal and more efficient. At least in the field of autism research, a major barrier has been the diagnostic tools that are being used. I think it's kind of ludicrous that, to get a diagnosis of autism, you had to pay a publisher for the diagnosis. And frankly, the expertise that's needed to learn these tools, behavioral tools, and to administer them is also in short supply in many communities, especially low-resource community. So the process we embarked on, actually last month, we started that. We brought together professional societies, so International Society of Autism Research, parents, cultural anthropologists, global mental health experts, World Health Organization, CDC, NIH. So the funding agency, pretty much all the stakeholders we can think of. And then we start to deconstruct the tools that we have at the moment, try to find out where the gaps are, and try to put together what we think are the common elements for effective screening diagnostic tools for our community to be used worldwide, and that can be administered by non-specialists. I think one of the most important recommendations that came out of this process is that in order to develop a tool that has potentially that universal applicability, you say you need to conduct field trial globally in different cultures simultaneously. That gives you the power to generalize, and it also gives you an opportunity to identify elements that may be transcultural, maybe things that may need to be additionally considered for specific cultures. At least that's the approach we're taking at this point.
So, David Keller, Children's Colorado. Two thoughts. Measured development, it seems to me, has happened in two contexts, and always around use. So somebody needs to use it. And in one case, we pay people to develop measures. Two examples of that are that the Secretary of Health and Human Services annually signs a contract with the National Quality Forum to encourage them, to basically set the parameters about what measures they should be encouraging to be developed and recognized by the NQF. And I know that in 2010, that contract included a priority for children's health measures. I think it lasted for about 2 years. I don't know I haven't seen the current contract, so I don't know if that's currently in there. So that's one mechanism. I don't think that was terribly effective at developing new methods. The other one was at that same time when the CHIPRA legislation was being passed, we put a bunch of money into the CHIPRA legislation to encourage the development of new measures and testing of old measures. That, I think, has been more successful. So this is one of those problems where putting money at it actually could develop new measures. The other times that we've developed measures is when we needed them for payment. And again, our colleagues in the adult world have been very successful at developing lots of measures. That's because they need them to be able to administer value-based payment formulas. And we need to be really aggressive at coming up with the measures that are going to be the basis of what value-based payment is in the behavioral health and child health space. And I think that's the other lever that we have is thinking hard about that. I'm involved in some of those efforts at a state level, and I know that it's tough to come up with what the measure should be in pediatrics that's the equivalent of the hemoglobin A1C control in adult medicine. We don't have that yet, and we need it.
Can I make one comment as well? Rachel Gordon, University of Illinois at Chicago, and I'm going to talk tomorrow, but I wanted to say something that I'm not planning to talk about tomorrow, because the issue has come up about developmental variation and cross-cultural variation and variation by race and ethnicity. And I work across a number of different disciplines, and I've gotten back into psychometrics in the last decade or so and really see variation across fields and how much they're using modern psychometric tools. The cross-cultural context is one in which there's been the greatest development in terms of thinking about how concepts vary across cultures, how the expression of behaviors vary across cultures, and we can use item response theory tools to understand those. I shared a piece that I wrote for family scholars because in psychology, what we know from surveys of graduate programs is that measurement in general is taught less than other techniques like ANOVA and regression, and IRT especially little. But we can leverage those tools to link, so we can address the developmental issues, and we can also understand more rigorously variation across different subgroups.
Great, and I think those are really important comments in here, because we don't want a measurement system that leaves out groups or is not relevant to large portions of our population that are particularly burdened by less access to care and to health disparities. So I think those are right on target in here. One thing, when in a previous workshop, Richard Frank gave a presentation here, and one of the things that he talked about was using finance as an economic, as a leverage tool to get things that you want. And clearly, he was mostly speaking around this issue of trying to get healthcare to improve the quality of services and the delivery of effective services to a broad population. But I also think that those same kinds of principles might be useful for doing the same kind of thing of integrating a broader perspective of measurements that could be used as actionable information. And if we were to invest in infrastructure and support infrastructure systems that were paid for their actual use rather than their availability, it may be a way to turn this around to promoting more effective use of data. And particularly if we think about data systems that might be useful for across purposes, and we've all been talking about coordination across different disciplines and across different silos that we've ordinarily had here. But if we had a investment system in what we have now is often a patchwork system, particularly in the prevention field and particularly in children's mental health, to an integrated system that was supported by its actual use. And there was a recognition that the more that people use that data, the more valuable it was. I wanted to see if anybody had any thoughts or comments around how do we integrate and get past this kind of system of everybody wants to do the good thing, but nobody's got enough investment to try to do it. I'm going to start picking on somebody. Picking on somebody to talk. I mean, I think we're at this point where we all are going in the same direction, but we want to move past this kind of general place where we are. David, you made some comments about, assessing communities at a local level and how we, should be doing something more than what we're getting at national and state level data. Maybe. Do you want to say something about that came up in the group?
Yes. Well, I don't know if this is what you're after, but I think that what we've learned in the work that we've done is that if you have data that you can trust, and you provide those data to people in ways that they can understand them, that communities will use data to make better decisions for children by deciding what are epidemiologically widespread risk factors, what are epidemiologically depressed protective factors in communities, and they'll actually use those data to make decisions. And the thing that I was talking about earlier in our small session was that sometimes it's frustrating to me to see federal agencies that get this idea that prevention really needs to be done locally, who really support with, for example, SAMHSA supporting the drug-free communities, actually doing the drug-free communities choice of those, et cetera, and really wanting to rely on communities and empower communities to make better decisions based on data for the development of their children. And we've seen in the work that we've done in the experimental trial of communities that care that when you do that, you really can find communities that get better outcomes community-wide for their young people. But it's frustrating to see that SAMHSA, which is the agency that's supporting a lot of that through SPF-SIG work and other kinds of work and drug-free communities work, doesn't support local communities to collect the kinds of survey data that are used for local decision, that can be used for local decision making. Instead, they rely from 12 to 17-year-olds on household survey data that are collected from very small samples, which can then be used to estimate state-level prevalences and epidemiological data, but can't be used for local community planning. And so SAMHSA, which started state partnership grants and got states involved in doing statewide surveys that survey using school-based surveys, 6th, 8th, 10th, and 12th graders, they started that work. They supported that work. States got involved in doing those surveys, and many states are continuing to try to conduct those surveys. And yet, when the recession hit, as we heard earlier, a lot of those states said, well, we can't continue this because we don't have the funding for this. While at the federal level, we continue to do the National Household Survey and include 12 to 17-year-olds, and those data can't be used for local community planning because they're not at the local community level. So there's kind of this interesting mismatch between what SAMHSA, I'm using this as one example and not making it the whipping boy, but just one example. Okay, well, So you have these surveys that are useful for certain purposes, but they're not useful for the purpose that would be the most empowering purpose, which is to give data to local communities that they can understand and use for local planning. And so somehow we need to solve this problem. And I don't know exactly how that happens. We've tried in conversations with people at SAMHSA to say, look, this is kind of a mismatch between what you think really needs to be done and what the data are that you're collecting. How can we help this happen better? Could people use their block grant money to support the school surveys that are done in communities and then given back to communities by states, et cetera? So I don't know if this is what you were interested in, but that was a concern that we've seen because it costs money to do those surveys. States are not at the present time. Some states invest their own money to do that, but if they don't have enough money to do that, then the survey goes away, and all of a sudden people who are relying on those data to be planning and evaluating and assessing the effectiveness of what they're doing at the community level, all of a sudden the survey's gone and they don't have the data that they need to be able to monitor their progress over time and continue to improve the quality of what they're doing based on outcome data. Was that what you were
thanks,
after?
David. Yeah, I do know of states that are using some of that their funds in order to provide local evaluations of data, particularly school surveys and the like. But I think that what we have is strategically it's a patchwork. And I do think that there is a potential of trying to find ways to integrate it, not only with the data that SAMHSA and CDC and a few others have done, but also there's other sources of data that could come into play as well. Maybe they're not exactly the same kind of quality, but what we know about is that it isn't too hard to calibrate household data against school data, even though they say the rates are quite different from each other in here, but you could try and find ways to calibrate and do something much more systematic.
Just one other thought that came up in our group. It would be very interesting just to do a little pilot work in some community and say, what are all the data that are really available on this community? When you start looking at it, you can get data from the Fed, you can get data from all kinds of agencies about economic outcomes and how they're related to specific communities. You can get criminal justice data on that community level. You can get economic, environmental data. You can get data from Zillow. You can just think of all the data that are available that could impact on our understanding of what a community looks like in terms of child development. And I really think that the presentation, from Bob this morning about what Chapin Hall has done, when you put those data sets together and you all of a sudden see that in these multiple impact communities that 81% of the families in those highest multiple impact communities are families where there's been abuse and neglect or some interpersonal violence in the family, you say, oh my goodness, this really does drive us to think about preventive interventions that would happen in communities, which takes us back to an issue that we talked about in our very first forum workshop, which is how do we get to the people who are raising children the ability, the capacity, the skills that they need to be successful in raising their children. I think all parents and adult caretakers want their kids to be successful, but don't always have the skills and tools and supports to make that happen. And yet we see from the data, when you bring all these data together, that this is really the nub of where it starts. He said this morning a really powerful statement. Those kids are on the street because it might be safer than being in their home. Well, if that's what the situation is in those multiple impact communities, we know that with healthcare reform, people are going to have insurance. More and more people in those communities are going to have insurance. Will the insurance pay for those adult caretakers to have the skills that they need to raise those kids without neglecting or abusing them? Because if they did, if they could, and they had that resource, we might have a very different set of outcomes in those disadvantaged communities. So I think putting the data together and then thinking about what are the implications for practice really becomes a very important thing for us to be doing.
I want to build off what David was saying, or maybe even kind of give a prequel to it in response to your question about, maybe we've been talking about some of these same suggestions for many, many years in many different groups, and, some of the progress just doesn't seem to happen. I was very struck by the kind of 20,000 foot level or mile level that some of this comes down to values, basic values. I mean, when you think about the strategic framing work that's been done, that some of those values interfere with research being put into policy because people just have these sort of inherent cultural beliefs about things, and one of them here is data and about being known and who knows it. So if those things are kind of really obstacles, which they are in really virtually any area in terms of implementing something and having consensus, then it seems like we really have to differentiate what kind of measures we're talking about. Some of it's administrative data, and that's, de-identified and different. But we also talked in our group, which was group 1, about how some parents don't want a history of mental illness in their family to be known. They don't want it in the medical record. They don't want it anywhere. And we can't pretend that's not true. So when you're not talking about administrative data, then you're talking about different obstacles than there are to administrative data being, advanced. Maybe that has to do with collaboration and some other issues that are also value-driven. But when you're talking about sort of personally reported data or patient-reported data, I think the obstacles are different, and I think maybe we have to tackle the bigger issues instead of continuing to generate good suggestions that have to do with more of the sort of mid-level or micro levels, issues. And I don't have an easy solution, but I think it's partly a value issue, both on the part of collaborators and on the part of families and people.
Yeah, this is Joyce and David. I welcome your comments. I don't speak for all of SAMHSA, but just perspective. I thought it would be helpful maybe to share some of the work we're doing with the state-supported Safe Schools, Healthy Students, which the funding goes to the states as a grant for five years, and then they select 3 local communities. And some of the lessons I think that we're learning from that is that communities are at very different levels, as we well know. They're asked through the grant to form a coalition or a community management team. So we're asking them to, do that coalition building and to engage families and young people, education, mental health, and other partners. But what's interesting is that partnership between state and local communities is one that in many states really hasn't been well oiled. And so tremendous technical support needed to help kind of change the paradigm and the culture of how states and communities work together. And some are very good and some are really stretched to do this work. I think we've got to look at that. Also, the technical assistance and support in local communities about what kinds of data. There's a plenitude of data, but then they're asking these grants to do a needs assessment environmental scan, use that to inform the development of a logic model and comprehensive plan, because their first year has been a year planning grant, and then move into, which they'll be doing very shortly, their second year of implementation. And that process with the 3 local communities and the state, and the dialogue, the relationships, how you use that data is something, and this is somewhat of a pilot, we're learning, but I think there will be lessons that we can take away from this that might be valuable to this work. Because it's, again, it's not so as much a technical challenge as I think, there's a lot of adaptive challenges in this work.
Thank you very much for those comments in here. One thing we haven't mentioned, I just wanted to get it on the table in here, when we talk about data, I think we mostly, many of us probably, mostly assume that we're talking about quantitative measures only. But I do think that there's really great opportunities for using qualitative data very strategically, particularly when we're talking about implementation, and particularly when we're talking about adaptation of programs and how do we make those work effectively in here. So I think I just wanted to make sure we had a broad vision of that. You know, it can be very expensive to do some of these assessments, but I think that it's also something that if we lack access of knowledge about why people might or might not be using information or availability of services, we'll get nothing, you know, from a survey. Well, I think we've come to a steady state in here. We've been going from 8:30 this morning. I know this has been a very intensive day. We have an intensive day also tomorrow for people in here, and we have 2 sessions which we're really going to be talking about engaging as well. So as far as I'm concerned, I think we can leave. Bill, do you have any last minute comments?
Very last minute comments. Just first of all, thank you. And secondly, you know, there are lots of systematic challenges in the healthcare system that have been there a long time, measurement systems being one of them. But I think it's important to remember that the forum got going really because of 2 things. One is the remarkable scientific progress in developing preventive interventions and trying to think about the challenge of widespread implementation. And the other, I think, a lot of different calls for reform that certainly as a healthcare provider have crystallized in part in trying to implement the Affordable Care Act. So yes, there's challenges that have been there a long time, but there are also opportunities that we have, and we're trying, Hendricks and I, and all of you are trying to think about where are the most effective next steps that we can take on this journey to try to widely implement what we know works. So thank you.
And we will see you tomorrow then. Thanks.